First of all, welcome. A few logistics. Hopefully you received a number as you came in the door, but because of this last session running a little bit late, if you didn't get a number, Farida will be coming. This is an interactive session, so you'll need that number as part of the session. So Farida's, who's in the blue jacket, will be handing out numbers. Please keep a hold of that for later on in the session. Great. Well, welcome all this morning, Karibuni, and welcome to the forum Enacting Tanzania's Primary Healthcare Approach, Stories from the Field. My name is Alice Christensen. I'm a nurse by profession, and I'm currently the country director of Jhpiego, Tanzania. I would like to acknowledge our government of Tanzania, government of Zanzibar, colleagues in the room, alongside USAID and other donors, as well as implementing partners and other health stakeholders in the room. You're very welcome. Like Tanzania, Jhpiego has always focused on primary health care, as it aligns with our mission to create and deliver transformative healthcare solutions that save lives. And our belief system is grounded in the tenet that where someone lives should not determine if they have access to healthcare. Jhpiego has recently redoubled our efforts to utilize a primary healthcare lens across our projects and in the countries that we work in an effort to strengthen health systems to improve both access and availability of quality healthcare to achieve better health outcomes. In Tanzania, our projects co-design, co-plan, and co-implement with the government of Tanzania and Zanzibar, and naturally, therefore, our projects prioritize a health system strengthening approach, which strengthens the primary healthcare system in alignment with the government priorities. I'm very honored to present a very impressive panel today, but before I do, I wanted to walk through the format of today's forum. We will be having two parts of the forum. The first is a moderated panel, which will run for probably less than 45 minutes because we started a little bit late. And then the second part is a gallery walk. So the gallery walk, our panelists will actually join the posters that are around the room, and you will break up into small groups, which is why you have the number, and you'll have hopefully a time to have more intimate discussions about primary healthcare and the approach through the gallery walk. You will hear a bell when you're going to rotate round, and then at the end we will reconvene. We'll have some small reflections, and I've promised Grace, who's here, that we will end on time so that the next forum can start on time. So that's kind of the logistics, so please grab a number if you haven't. So now to introduce the distinguished panel today. So I have Dr. Ntuli Kapologwe, the Director of Health, Social Welfare and Nutrition Services at P.O. Ralph. Many of you saw his face last night, and he's a key proponent for both the Tanzania Health Summit, but also a visionary in primary health care. He's a strong advocate for quality services and the expansion and support of PHC in Tanzania. He is also the lead editor of the book, Primary Healthcare in Tanzania Through a Health System Lens, which was just recently published on Amazon. So if you're interested, come and you'll see his poster, and also you can always purchase his book, which I have read and is fascinating and a really great history of both health and primary healthcare in Tanzania. We have Dr. Gemma Bisimba, who is a public health specialist, who currently serves as the advisor to the USAID Bureau for Global Health Primary Impact Initiative, focusing on strengthening primary healthcare services for universal health coverage. Then we have Dr. Rita Naronha, who is a public health specialist, who currently serves as the chief of party for the USAID Afya Yangu Reproductive Maternal Newborn Child Adolescent Health Project, which aims to improve quality and access of RMN-CAH services across 11 regions in Zanzibar. The project uses an integrated approach in an effort to improve primary healthcare services, which will aid the outcomes of women, adolescent girls, children, and newborns. And then definitely last but not least, someone who is a professional nurse like myself, Nurse Jalia Rwenza is a primary healthcare nurse working to provide health services, including immunization, delivery service to pregnant women, family planning, medical care to patients, and the whole gamut of primary healthcare services. Welcome, Jalia. So, the primary healthcare concept was introduced in Tanzania in 1967 during the Arusha Declaration. and Tanzania launched the 10-year PHC development program from 2007 to 2017. In the last few years, the government of Tanzania has recommitted to providing high-quality PHC to all of its citizens as a best way and a best practice to achieve universal health coverage. This commitment is clearly seen in new strategies and implementation, and PHC remains an important entry point for individuals into the health system, improving health awareness through disease prevention, diagnosis, and treatment. And it's critical for pandemic preparedness and outbreak response, as we've seen with COVID-19. The majority of reproductive maternal, newborn, and child health services, along with key communicable and non-communicable disease interventions, are delivered as components of a strong primary healthcare system. Tanzania, alongside the global health community, are recommitted to investing in PHC because it provides over 90% of essential health services, addressing the health needs across the lifespan while improving health outcomes, health system efficiency, and health equity. We will now have a discussion with the panelists on specific PHC perspectives from the government, donor, implementing partner, and frontline worker perspectives. Welcome to the panel. I'll start with Dr. Ntuli. Dr. Ntuli, the government of Tanzania is prioritizing primary health care and taking bold action from policy to implementation. What achievements are you most proud of, and what are your next priorities with PHC in Tanzania?
Thank you very much, Alice, and let me take this opportunity just to thank you and the Jhpiego team for having invited me to this very important panel. PHC is very close to my heart, so speaking on matters relating to PHC is quite something which I feel very much good. With regard to the question which you have asked, I think we need a little bit to go into the definition of PHC, which is dated back to 1978, which was co-created by UNICEF and WHO. There are some of the key words as far as the definition of primary health care is concerned. The first one is on the essential health services, which are delivered practically and which have to have scientific evidences, but also need to be socially acceptable. But in that definition, went further to say that these services should be rendered to the individuals, families, and the community. But community participation should be at the core of primary health care delivery. And also spoke something on the services that are provided by primary health care should be at the affordable range. So these are some of the things which makes really primary health care very unique, and for us to be able to achieve universal health coverage, to be able to achieve sustainable development goal before or by 2030, really we need to invest into the primary health care. But I must say that primary health care is quite very complex. I see some of the people, they think primary health care is linear, that you can move from one point to the other, but no. Number of issues around the primary health care, they are intertwined. You cannot deal with one thing and then leaving the other thing to come later, and then you say, I'll be able to achieve. You need to take everything together for you to be able to achieve. Although I do not undermine the importance of prioritization, you need to prioritize, but at the same time, you should know the complexity which exists between the primary health care space. Now, with WHO 6 building blocks, these blocks have done wonders for a number of years. Everyone resorted into that framework. It seemed to be working very well. But of late, we came up with some issues which made us think that no, we need to look again into these building blocks if they are responding to a number of issues and challenges which we have. So to these 6 building blocks, Now we have added some other building blocks as per Tanzanian context. So we invited over colleagues from the non-state actors, from development partners, implementing partners, and from private sectors. We came into the meeting and discussed, are these 6 building blocks exhaustive? No. Then we went into some other building blocks, which is beyond the building blocks. The social determinants, they are not well captured within those 6 building blocks as per WHO framework. We have the political determinants. We have the commercial determinants, and what have you. So with that, we could clearly see what Tanzania, especially the government of Tanzania, has done together with its stakeholders is quite very tremendous. So I'll divide the achievement which we have been able to get so far into those which are facility-based and the other ones which are community-based, because the community healthcare system is embedded into the primary healthcare as per Tanzanian Organization of Primary Healthcare System. Our arrangement is quite very unique from other countries where you have a community healthcare system detached from the primary healthcare or partially detached. But for us, that is included within the primary healthcare. So with community healthcare system, we have witnessed the use of the community healthcare workers, especially in response to number of diseases, including the COVID-19. We were able to use the community healthcare workers to respond to COVID-19. And that was a game changer. Initially, we approached the COVID-19 response by basing mainly on the facilities. But later we realized that we need to take the community care workers on board and to make sure that the communities are part and parcel of that conversation for us to be able to achieve. So one of the achievements which we have witnessed recently is in the response to COVID-19, response to measles outbreak and response to some diarrhea outbreaks. We were able to work with communities, we were able to work with community healthcare workers, and we were able to contain the disease condition. But the other thing which I can clearly see that is one of the achievements is the fiscal decentralization. Before 2017, monies were dispersed from the treasury up to the district headquarters. But after reforms of 2017, now monies are sent directly to primary healthcare facilities. Now the primary healthcare facilities are granted with the autonomy. The decision-making space at that level is increased. People are planning, people are budgeting by engaging the people from the community. We have the community governance structure, the health facility governing committee, working together with the facilities to plan together. They budget together, they implement the budget together. They do monitoring and evaluation as well as inspection. So this is one of the achievements as well as far as what we've been able to get in the past 5 years as part of the reforms. The other thing is on the issue of decentralization of services. Initially, there are some of the services which were provided by secondary and tertiary level facilities. But as I'm speaking to now, and this is to allude to what Honorable Minister Umi spoke yesterday, there are some of the services now, including the emergency services, having the emergency department facilities, ICUs, having the X-rays, ultrasound at the lower level. This cannot be understated. This is a huge milestone because if we compare ourselves to some other countries in the regions, we rate ourselves higher, somewhere there. So the most important thing now is to sustain that one. The other thing is on the issue of quality. You know, quality is also a very complex thing, but I usually resort to one of the scholars of the quality, who is Donna Bedian, who gave the definition of quality in 1975. And he actually pointed out 3 components. The first one is structural quality, the process quality, and then the outcome. With the structural quality is where the issue of human resource for health. Now, we have decentralized even the human resource for health money. Initially, MDs were mandated only hospitals, but now we have at the health center level, the biomedical engineers, the accountant assistants. So this is a huge milestone, and we are seeing the evolution. And this one is also achievement to that one. Having the ambulances to strengthen the referral system, the continuum of care, these are also some of the achievement. But also, when you look into processes, now there are a number of guidelines to assist our colleagues, especially the frontline workers who are working at the primary care level, to be able to execute their duties smoothly. But when it comes to the outcome, it is quite very clear. We had a maternal mortality of 556 per 100,000 live births in 2015-2016. But as per data which is not officially advertised, now we are somewhere at 250. That's massive. And to me, the main attribute is the primary health care. We have constructed a number of facilities across the country. We made services accessible within 5 kilometers, but at the same time, the facilities are manned with skilled personnel. So these are some of the achievements which I thought I should share with you, but we thank very much the primary health care, but the supporters of primary health care. And I must say that primary health care is the foundation of universal coverage and sustainable development care. But primary health care is by the people, for the people. Back to you.
Thank you so much, Dr. Ntuli. You can see his passion. So from my takeaways from that, community is absolutely vital, not only community engagement, but community services, and that Tanzania has really prioritized that by helping decentralize. So they've done a lot of work on decentralizing services, including bringing down, as the Honorable Minister said yesterday, services to the primary healthcare level, and then strengthening the quality services. So thank you so much, Dr. Ntuli. We will hold questions for now because you'll have time to engage with Dr. Ntuli and his poster at the second part of the session. So I'd like to now move on to Dr. Gemma, who's representing USAID today. USAID has recently recommitted to primary health care and has launched the new Primary Impact Initiative, of which we're very lucky to have Gemma as an advisor on that. Can you share some of the examples of promising progress in primary health care that you are seeing globally, and what USAID's priorities are for supporting primary health care in Tanzania? Over to you, Gemma.
Thank you, Alice, and good morning, everyone. Again, thank you, Jhpiego, for organizing this very important session. I think to respond to what you have asked, USAID, as you all know, is a U.S. government development agency to support health among other development agendas. And recently we have launched what we call Primary Impact. It's a global initiative basically to accelerate strengthening primary health care in countries. And this has come recently. As you said, we have recommitted because we've been working into primary health care back in the years, but again, because of these emerging diseases, as you know that we have been really focusing into the disease-specific support, but now we are recommitting to going back to integrating and strengthening the primary health care. And this is because we want really to address the inequities that have been seen in the healthcare services, and we think that strengthening the primary health care is really the key to making progress towards our development goals in the health sector, starting from improving the maternal and child health care, the nutrition status, adolescent health, and even preparedness for the health emergencies. So we really want to support countries recommit. Also, we work with the countries to recommit into strengthening the primary health care. And going into the countries, we have seen countries that really have committed or put investment into the strengthening primary health care have really shown a big impact within a very short period of time. I'll give an example from Ethiopia, where I was in the past few weeks, and we visited what they call their flagship program called the Health Extension Program. This is basically using the primary health care principles, and what they've done really is to put resources or investment into strengthening primary health care using the community health workers. They call them the rural or village health workers. So what they're really doing is to connect the facilities and communities through these facility health teams, where they go into the communities to provide the basic preventive and curative services. As we all know that with limited resources, especially these low and income development countries, we cannot really build facilities or have infrastructures everywhere. But then using these minimally trained healthcare workers really can support to reach the unreached populations. And with this program, really they've started it in around, I think, 2004, but within a very short period of time, they were able to reach around more than 50 million communities in the rural population, especially pastoralist communities who have not really been accessing care before this program. So we have really seen that it is help the country really to expand their access to services. But also with that, they've been able to reduce about 66% to reduce the child mortality rate within that same community. So you can really see that strengthening the primary health care has really huge impact into accessing services, but also the quality of care. And we're also seeing the same results in a country like Ghana. They're also doing the same. They put resources to kind of institutionalize their community health worker program. Again, is to link between communities and facilities and expand the services to the communities where we cannot reach from the facilities side. And with this, again, they were able to, within 3 years, they were able to reduce the child mortality by 50%, but also increase the immunization coverage, increase the family planning uptake, and all these other health indicators. So really is to recommit our resources into strengthening the primary health care, because that's where we see now we'll get results within a very short period of time. So with this primary impact initiative, what we are planning to do, currently we've started with 7 pilot countries. Unfortunately, Tanzania is not one of them, but it will be in the next phase. So what we are really looking is to help our countries really recommit their resources into strengthening the human resources for health, and specifically the community health workers, because that's where really we can reach the unreached population. But also we are looking to strengthen service integration. As we said, we have been really into disease specific and program specific, but now we want into integrating services where the people are, in the communities, but also in these lower level facilities. So we move from the silos of disease specific interventions. And again, is strengthening the health systems functions, supply chain, but also the health information system and health emergency preparedness. Yeah.
Great, thank you so much, Dr. Gemma. So the community is coming through in both Ntuli and Gemma. I think she gave some really nice examples of how investment, especially at the community level, is really having impact on some indicators that have often stagnated because of investment in kind of the disease-specific approach. So I think that that ties nicely. Although Tanzania is in the next phase of the primary health initiative, USAID has invested in very strong and integrated programs. And Dr. Rita Naronha leads one of USAID's integrated programs, particularly focused on RM&CH. So Dr. Rita, can you please share your experience on how USAID Afya Yangu RM&CH program strengthens primary health care to deliver quality RM&CH services? And what do you see as some of the successful approaches that you're excited about? And what are some of your challenges? Thanks, Dr. Rita.
Thanks, moderator. I'm pleased to be part of this panel. Thanks for the opportunity. Like you said, 90% of essential health services, including RM&CH services, can be provided through primary health care. And so primary health care holds a great potential to improve maternal, newborn, and child health outcomes. As you said, USAID Afya Yangu is implemented in 11 regions. We're covering on the mainland and Zanzibar, we're covering about 90 councils and more than 2,800 health facilities. And more than 90, I would say more than 90 health facilities are actually primary healthcare facilities. So and when we talk about maternal health, it's really a health system issue, and our approach is really health system approach. So we are supporting, as Afya Yangu, we're working very closely with the regional health management team, but most importantly with the health facility in charges and healthcare providers to support facilities to offer integrated, quality, respectful health services. And we do that along the continuum of care from pre-pregnancy, pregnancy, ANC, intrapartum, postpartum. We also, as Dr. Ntuli said, with decentralization of comprehensive emergency obstetric care services at the health centers, we also support health centers to initiate the new upgraded health centers to initiate CMOC services, and we use local resources. We use the secondary health facilities. We use regional referral hospitals to support health centers to deliver quality comprehensive emergency obstetric care services. But we also, in terms of equity, we know even with the constructing health facilities in villages, etc., there are still some communities that live very far. So we do support facilities to do targeted outreach services. And one of the good examples is Village Health Nutrition Days. We've implemented that in Katavi and in Tabora. And it's not only about screening for nutrition, but really providing integrated services, providing immunization services, providing ANC services, and family planning services. And we have been able to also, through the Village Health and Nutrition Day, identify households with vulnerable kids or vulnerable communities and link them to TASAF or link them to the community structure so they can get support. But coming to human resource for health, our core focus is really using innovative, cost-effective, evidence-based capacity building approach. We use blended learning. We support on-job training using low-dose, high-frequency, but using the mentors that are trained in the councils to support primary healthcare facilities. We also use e-learning. We have developed more than, I think, 8 e-learning modules that are on the government platform that can be accessed. These modules are accredited by professional councils, so when you undertake the course, you not only get knowledge and skills, but also you get your CPD points. We also support health facilities on data management, particularly healthcare providers, to improve documentation, but also data visualization, select indicators, and all these are linked to quality improvement. So select indicators, do data visualization, track performance of the facility. We also encourage and support them to use data to target interventions. For instance, we support facilities to identify areas or geographies with zero-dose children, and then use community health workers to identify the households of the kids, and then support providers to do outreach services. So that's how we use. So in addition to improving the quality of service, but also using the service to target interventions, to target capacity building support. In terms of supply chain management, we work closely with other USAID-funded activity, global health supply chain, but we also use the impact team and also the district pharmacies to support health facilities, primary health facilities, to do better forecasting, to use the consumption data, to use the data that they collect, to do better forecasting, but also to fill in the request and reporting form, the RNR form, and commodity distribution. In terms of strengthening primary healthcare leadership and governance, we We support, we strengthen the functionality of quality improvement team so they can really focus on quality, looking at data and tracking performance of the facility. But we also work with the Health Facility Governing Committee to really encourage most of the experiences, most of the time, the Health Facility Governing Committee, we look at the admin issues like the expenditure, the budget, etc., but not so much on the quality, not so much on the quality or the client's complaints. So really engaging them to not only look at the admin issues, but also the issues of health facility performance and quality. And in terms of, we also work very closely, we use community health workers to improve linkages between the community and the health facility. We use the unified community health system, which is a government digital health community system to really link communities to health facilities. In terms of the challenges that we see in implementing this, much as we say we need to invest in primary health care to deliver quality services, and I was in the previous session, we were talking about the new Ministry of Health, HRH recruitment plan, the acceleration recruitment plan, and in that plan indicates that 70%, at the dispensary level, we have 70% shortage of HRH, and we also have 63% shortage at the health center level. So imagine with this shortage, it's difficult to ensure quality service at that level. So it's really about the shortage of human resource at this primary health care level and the quality, the quality in terms of the skills of providers at that level. The other challenge that we see is really health facility readiness to respond to emergencies, and particularly at the health center level, in terms of they are expected, because of the decentralized care, they're expected to really manage obstetric complication, newborn complication, child health, but are they ready when the complication comes in? So that's really our role, and we are leveraging the technical support, the technical expertise from professional associations to support the health centers. And the last challenges that we also see is leadership and accountability. That's really a challenge. Much as we do the training, you know, we provide tools, etc., but really improving the quality lies on the provider, and you need close supervision, close mentorship, and sometimes really beyond the project to enforce that accountability. And we have seen in facilities where we have strong leadership, or councils where we have strong leadership, with the same level of resources, you see better performance. So again, leadership and leadership governance and accountability is really critical. The approaches that I see exciting really is it's our innovated capacity building approaches, which are really sustainable. The e-learning course, one can access the course. It's in the government e-learning platform and take the course. But also we also establish learning corners within the facility, and we really promote peer-to-peer peer practice at the facility level, and that's really very sustainable. But the other exciting approach is really linking, because we know we really need to utilize the secondary level facilities, whether it's regional referral hospitals or no hospital, to support the primary health care facility. So really strengthening the networks of care to improve quality of care at the primary health care facilities. And last is but not least, is the community scorecard approach. It's powerful and very effective. I was just reading a report from one of our CSOs, and it was a community scorecard implemented in one of the councils in Manyara, and one of the complaints that that they put forward was the unfriendly provider, long waiting time. But they said we don't have an effective health committee in this village. So please put up the health committee so that they can listen to our complaints. So that's really engaging community through community scorecard is really powerful. Thank you.
Great, thank you, Rita. I think Rita illustrated what Ntuli said, that it's not a linear thing to improve primary health care. There's many different pieces, the building blocks, which Ntuli will talk about at his poster, but also some other factors that affect the building blocks. So I think Rita has a very challenging project, but I think that the alignment with the government priorities and looking at that systems approach will hopefully have good results. So last but definitely not least, I wanted to have Jalia, who is one of our frontline workers under the USAID Afya Yangu project, how she is, how she is kind of enacting this. So Jalia, in your work every day, what are the best practices that you use to make sure that people are receiving the services they need, especially the most vulnerable?
Asante kwa nafasi hii. Kama primary healthcare worker, nafanya kazi kwa kushirikiana na wahudumu wa afya ngazi za jamii ambao ni community healthcare workers kwa conduct community mobile outreach ambayo ni huduma za mkoba. Tunapeleka huduma za afya kwenye jamii ili kuhakikisha wanapata huduma muda wote. Hii ni kutokana na changamoto za miundombinu ambapo umbali inakuwa ni factor ambayo inapelekea hivyo. Kupeleka sisi huduma kwenye jamii inasaidia wanajamii kupata huduma muda wote. Asante.
Thank you, Jalia. So I think Jalia gave an excellent example of how she's using an innovative approach to reach the communities that need it most, especially the vulnerable. So thank you. So now we'll break into the second part. So we're going to make you do some mazoezi. So if you received the number ones, if you could join Jalia right up here on the front around the primary health care in action. Number twos, if you could join Dr. Ntuli by his poster here, primary health care in Tanzania. Number threes, you can join Rita right here around leaving no one behind. And number four will be Dr. Gemma in the back corner, I believe. Is that right? Frank, okay, so let's move, sorry. Number ones, Jalia's poster will be in the back corner. Number fours will be by the screen with Dr. Gemma. And then we'll give you around 7 to 8 minutes. And then when you hear the bell, please rotate in should we do clockwise? I guess a clockwise rotation. Thank you so much.
All right. Recording unaendelea.
We have 1 minute before we rotate. 1 minute. So we're gonna go clockwise. Yeah. So if we can move clockwise around. Wait, clockwise. Oh, clockwise. I'm sorry, you're right. I was turning around. So you guys are moving over to Dr. Gemma. You're here. In Tuli's group, if you can move to Jalia, please. And Dr. Gemma's group, move to Dr. Ntuli. It's like a traffic jam in Dar es Salaam. Dr. Ntuli's group, we need you to move to Jalia. No one wants to leave it. Great. Dr. Gemma's group, please move to Dr. Ntuli. Going okay? 1 minute left. 1 minute left. Please go ahead and rotate clockwise. Dr. Rita's group will go to Dr. Gemma. Dr. Gemma's group will go to Dr. Ntuli, and Dr. Ntuli's group will go to Nurse Jalia. Like jam. Good, thank you, Dr. Rita's group. All right. Dr. Gemma's group, Ntuli's group always likes to hang out with Ntuli. Ntuli's group, if you can go to Nurse Jalia, please. Thank you. We lost some of the group. Okay. Anyone else joining Dr. Rita's group? 1 minute left. Okay, if we could do the last round of rotations, clockwise direction. Dr. Gemma's group to Dr. Ntuli, Dr. Ntuli to Jalia, Jalia to Rita. Dr. Gemma's group is looking very light. Did everyone move? Okay, this group thanks to move over to Dr. Gemma. Thank you. 1 minute left. Okay, if I could have the panelists please join us back on the stage and the audience back to their seats. We'll have a quick wrap up before we go on our way for the rest of the day. Okay, if I can have everyone take their seats, please, for a quick wrap-up. And the panelists are invited back on the stage. Great, welcome back from the gallery walk. We have about 9 minutes to do a quick wrap-up session. So I would just like to offer up to the audience, in clinical, where I was a nurse, we would often have clinical pearls. A clinical pearl was like a takeaway or something that you learned. So it's short and sweet, so maybe 1 or 2 sentences of something that you took away from the gallery walk. Do I have any brave volunteers from the audience that would like to share a PHC pearl from what they learned on the gallery walk? Yes, please.
I saw that the community health worker is very important in this journey.
Great, the great pearl. Community health worker is very important in the PHC journey. Any other pearls that you learned on the gallery walk? This gentleman right here.
Thank you. My name is Ambrose. From Tuli's presentation, I learned that we have not utilized the power of community leaders in making decisions for healthcare. And then from Jenna's presentation, we are fragmented at all levels, from donors to implementers. I hope we could be able to integrate. The interesting bit is that the same nurse or midwife at level 1 in my country in Uganda is not disintegrated. She's providing all the services, but the ones supporting her have no idea how to work together. Thank you.
Those are fantastic pearls and takeaways. Thank you so much. Any other pearls from the gallery? Yeah, this gentleman here in the front. Oh, this one here, and then Waziri.
Thank you so much for a very nice presentation from every member of the panelists. My comment is, as a country, we cannot achieve the universal health coverage without investing in primary health care. Everyone in the national, international congresses which we are attending is just stressing and talking on about primary health care. So it is a high time now for everyone in the country, from the sector-wise to the donor, to be very well integrated in order to make sure that we maximize the efforts towards the journey of universal health coverage. Thank you.
Fantastic, thank you. Great, Pearl. And Waziri last.
Okay, thank you. From Tuli's presentation, I learned that relevance is very important. The way the book has contextualized, because we have many guidelines or policies which are not applicable, but that was well done. You see, like this one can be applicable in our country, so congratulations to that. Back to Dr. Jema, I think I like the fact about financial tracking commitment. Most of the time we say we are going to include this into CCHP, but the tracking system is really poor, but at least if we see that a commitment comes directly from CMT, it gives us a lot of courage as IPs to keep on supporting. Jalia, yeah, people were surprising, like which transportation did you use? You know, who supported you? But we've done a marvelous job. Even in the primary health sector, other nurses, midwifery, they can do it. To Dr. Rita, we have seen palliative care. Everybody was surprising. How can you do promotive, curative, preventive? That was well done as well. Thank you.
Great, thank you. Very pros. Last one from this gentleman, and then I'm going to have the panelists reflect.
Thank you very much. I learned also from Dr. Ntuli on the approach of embedding the determinant of health and well-being in the primary healthcare system. This is very crucial because it brings in all the stakeholders to be engaged for the betterment of the health system. Asante sana.
Great. So we have 5 minutes, and I promised I would end on time. So very quick reflections from each of my panelists, 30 seconds or less.
Thank you so much. Just wanted to again reiterate that primary health care holds a great potential to improve maternal, newborn, and child health outcomes, and we need to invest. Financing for primary health care, but also human resource for health to deliver quality services at primary health care.
Okay, asante sana. Ningependa kusema kama community healthcare workers tufanye kazi kwa wito ili kufanikisha kiu ya wateja wetu.
Asante. For me, I think the takeaways is 3 things. That primary health care is an approach, it's a way of living. Everyone should enjoy primary health care. And health systems is a means to take us to the promised land, which is health for all. Then universal coverage and sustainable development goals, these are the goals to be achieved. Primary health care is by the people for the people. Asante.
Asante serikali. Yeah. I think for me, one big takeaway is that it's time now we get away from fragmentation and have integration of services. And it starts with us as donors. We need to have one plan, one program, one budget.
Great, and a reflection from me as the moderator is I'm so proud of us. I think we've all learned, I think we have some key pearls and takeaways, but I would really like, first of all, to acknowledge the audience. This was a different format and a different forum, but you guys did a really great job and you're really engaged. So please give yourselves a round of applause. And finally, I would like to just thank our distinguished panelists. They all have very busy schedules and they took time to prepare, do their posters, and I think we did a nice little rapid assessment, and I think that they could be very proud that their messages have gotten across to the audience. I think the pearls that were reflected back are some key takeaways, and the panelists should be very proud. So thank you each panelist. A round of applause for the panelists. Great, I have one final plug. Jhpiego is raising money for Miles for Mothers for a NICU. We have a booth right on your right. We're supporting the government's priorities to expand access by building a NICU in Quimba. So please buy your t-shirt, join us on a run on October 15th. We really want to do a successful NICU in Quimba. So thank you, enjoy the rest of your day, and I hope Grace is happy that we ended right on time. Everyone have a wonderful day. Thank you so much. Oh, we ended a minute early.